Welcome back, future pharmacist. In this lecture, we're diving deep into a topic that's not only crucial for your NAPLEX exam success, but also essential for your future career in healthcare. That's right, we're talking about hypertension, one of the most prevalent and significant medical conditions you'll encounter while practicing. All right, first things first, we're talking about normal blood pressure. In this stage, your systolic blood pressure, which could be abbreviated as SBP, is below 120, and your diastolic blood pressure, which could be abbreviated as DBP, is below 80. Systolic blood pressure is the number on top, while diastolic blood pressure is the number on the bottom. You can see here 120 over 80. In hypertension stage 1, your SBP falls between 130 and 139, or your DPP ranges from 80 to 89. When you find yourself in this range, the next step is to calculate your 10-year cardiovascular disease. In this case, it could be given to you on the exam. And don't worry, you don't have to know how to calculate this. Usually, in the patient case, you'll be asked a question and they'll give you, the patient comes in to the ER or, whether it's just a checkup, and you'll have to go through the case and see, if they mention the 10-year CVD risk and go from there. If the CVD risk is less than 10%, then as a pharmacist, your recommendation is for the patient to have lifestyle modifications, which include a healthier diet, exercise, stress management, and developing better habits. If the CVD risk is greater than 10%, we're stepping up the game with lifestyle changes and one medication into the mix. And lastly, if their hypertension stage 2, then their SBP crosses 140, is over 140, or their DPP is above 90. And it's time to take action now. If they come in, with one of these greater than 140 or 90, then you want to recommend 2 medications. And later on, we're going to go into which medications to recommend. But it's all about finding a right balance to bring those numbers back to a healthier range. All right, let's talk about an important concept in understanding blood pressure. This is mean arterial pressure, or MAP. MAP measures the average pressure in your arteries, and it's not just about numbers. It plays a vital role in assessing the blood flow in your organs. Think of it as a window into your body's cardiovascular health. It gives us a clearer picture of blood flow than a single blood pressure reading ever could. So why is this crucial? Well, it's all about ensuring that your organs get the oxygen and nutrients they need to function properly. Now, when it comes to the number, a normal MAP falls between 70 and 100. In critical care settings, MAP becomes even more important. It's a tool to manage patients' perfusion, making sure their organs get the blood flow they need. When MAP drops too low, it's a sign of inadequate blood flow. On the other hand, a high MAP can strain the heart and arteries, lead to other health conditions. So why does this all matter? Because MAP is a crucial indicator of your overall cardiovascular health. Maintaining a healthier MAP ranges is essential for ensuring your organs, again, to function properly. And understanding MAP isn't just crucial for the exam, it's crucial for when you're practicing in the future. And you will have to calculate the MAP on the NAPLEX. They could give you a blood pressure and ask you what is the mean arterial pressure in this patient. So let's try an example. As you can see here, the formula for MAP is going to be 2 multiplied by the DBP plus SBP, all divided by 3. So now it's your turn. Pause this video and let's calculate the MAP of a blood pressure of 102 over 70. Let's give it a try. So hopefully you had no issues solving that. You'll get 80.66, which could be rounded to 81. Now let's shift our focus to the practical side of managing hypertension through lifestyle modifications. These are the steps you can take to empower yourself in the battle against high blood pressure. First up, we have a DASH diet, which is a dietary approach to stop hypertension. It's more than just a diet. It's a roadmap to a healthier eating that's proven to lower a patient's blood pressure. Next, we tackle sodium. Limiting your sodium intake to less than 2.4 grams a day can significantly help in controlling your blood pressure. Remember, small changes here can make a huge difference. When it comes to alcohol, moderation is key. Limiting or even better, cutting down your alcohol consumption can contribute to a healthier blood pressure. And of course, let's talk about getting moving. Aerobic exercise, whether it's brisk walking, jogging, swimming, or cycling, either way works. Just moving is much better for your cardiovascular health. These lifestyle changes might seem small, but their impact is substantial. By incorporating these habits into your daily routine, you're taking a meaningful step towards lowering your blood pressure control and a healthier lifestyle. So it's very important that you recommend these for your patients. So for your NAPLEX exam, a lot of times you'll be given a patient and they'll give you a certain disease state and they'll ask, what is the blood pressure goal for this patient? And it'll be up to you to know what's their goal. So for a blanket statement, I'm going to say it's safe to go with less than 130 over less than 80, 130 being systolic blood pressure, 80 being diastolic blood pressure. This is including elderly. There are a lot of resources provided below. They're given a person with a disease state and they're asking, what is their goal blood pressure? It's a safe bet to go with 130 over 80. So now that we know a little more about hypertension and blood pressure, let's dive into the medications. So here are the antihypertensive drugs. So this class could be divided into further classes, and we'll break them down here and later on in this lecture. So first class, we have diuretics, which is broken down into thiazide diuretics, loop diuretics, and case-sparing diuretics. Next, we have renin-angiotensin system inhibitors. These act on the renin-angiotensin system, and these include ACE inhibitors, ARB blockers, and direct renin inhibitors. Next, we have sympathetic inhibitors, and there are several categories of these, which we'll go into. Next, we have calcium channel blockers, and lastly, we have vasodilators. So let's get into them. So here is a list of all the antihypertensive drugs available. And as a pharmacist, it'll be up to you to be familiar with these, to know their brand name, their generic name. For the NAPLEX, it's good to be familiar with the brand name, generic name, their MOA, mechanism of action, and their drug characteristics. So as a pharmacist, you'll actually need to know that as well while practicing. So let's dive into it. And it's good to know that the first line medications include CCBs, which are calcium channel blockers, ACE inhibitors, ARB blockers, and thiazides. And I have a mnemonic that helps with these, and that is CAT. So C standing for CCBs, first A standing for ACE inhibitors, second A standing for ARB blockers, and the T standing for thiazide diuretics. In the realm of hypertension medications, a lineup of powerhouse options take the lead in effective blood pressure management. This is known as the mnemonic we just went over as CAT, which stands for calcium channel blocker, ACE inhibitors, angiotensin II receptor antagonists, and thiazide diuretics. These are the foundational choices that play a vital role in hypertension. Tailoring medication to specific scenarios is key. For example, for African American patients without heart failure or kidney issues, thiazide diuretics or calcium channel blockers are favored due to the side effects of ACEs and ARBs. When chronic kidney disease, CKD, is present, ACE inhibitors and ARBs step up to preserve kidney function and regulate blood pressure. This holds true for individuals aged 18 to 75 with both hypertension and CKD. Meanwhile, in pregnancy, safer options include methyldopa, nifedipine, and labetalol are preferred, while ACE inhibitors and ARBs are cautiously set aside and not used due to their teratogenic properties. This is strategic selection of choices that ensures personalized approach to a hypertension management providing a strong foundational and comprehensive care for the patient. So it's good to know for the NAPLEX exam that if they're giving you a patient with hypertension, that you want to first seek out these CAT, which is going to be the CCB, ACE, ARB, and Thiazide. And in doing so, you want to, furthermore see if the patient has any heart condition, if they have CKD, their race could play a role. So it's important to take note of all these things during the exam. Hypertension, often asymptomatic, silently lurks as a prevalent condition. However, notably, elevated blood pressure can trigger symptoms. This include telltale signs like headaches, dizziness, retinopathy, or proteinuria. Such symptoms are often tied to the presence of vascular atherosclerosis, forming a nexus between hypertension and several interconnected alignments. Among these are coronary artery disease, congestive heart failure, stroke, and renal diseases. It's a reminder that behind the quiet facade of hypertension lies a more complex interplay that can significantly impact cardiovascular and renal health. Blood pressure reduction entails two key strategies. One targets volume reduction within vessels by acting on the kidney, while the other focuses on dilating arteries to decrease the afterload. Volume reduction is achieved by promoting sodium, salt, excretion, leading to the subsequent excretion of water, a process orchestrated by diuretics such as thiazides and loops. In contrast, vessels or artery dilation decreases afterload. Calcium channel blockers and various adrenergic blockers, including beta blockers, alpha-1 blockers, and alpha-2 agonists, play a vital role in this approach. It's noteworthy that these interventions can bring about cardiac effects influencing heart rate and contractility. Certain drugs exhibit a dual effect, simultaneously targeting both volume reduction and vasodilation. Within the realm of renin-angiotensin-aldosterone system, RAS antagonists, ACE inhibitors, ARBs, and direct renin inhibitors stand out. These agents tackle volume reduction by curbing aldosterone production, promoting sodium excretion, and thereby decreasing fluid retention. Simultaneously, they induce vasodilation by counteracting the constrictive influence of angiotensin. A noteworthy consequence is the alteration of potassium levels, as aldosterone regulates potassium secretion. Inhibiting aldosterone can lead to increased potassium levels. By vasoconstriction, these drugs pivot the balance towards vasodilation, contributing to a comprehensive approach to hypertension management. So this is all to say that through antagonizing the RAS system, potassium K increases. While many medications strive to lower blood pressure, there's a group that can inadvertently elevate it. Here's a list of the medications that could actually increase blood pressure. So I would recommend knowing these for the exam. In the NAPLEX, they could give you a question asking which one of these patients' medications could be increasing their blood pressure, and it would be up to you to know which medications will be doing that, and it could also be a select all that apply, so I would memorize these for the exam. So embarking on a regimen to reduce blood pressure involves strategic steps. Step 1 begins with lifestyle modifications, shedding excess weight, limiting salt intake to under 2.5 grams daily, adopting the DASH diet to boost potassium intake, engaging in regular physical activity, and moderating alcohol consumption. Step 2 introduces medications. These include calcium channel blockers, ACE inhibitors, ARBs, and thiazide diuretics. Progressing to step 3, the goal is to achieve target blood pressure within the first month. If not attained, adjustments come into play. This entails increasing medication dosage and, if necessary, adding another agent to the treatment plan. This strategic approach underscores the dynamic nature of blood pressure management, adapting interventions to achieve optimal results. So this is the approach you want to take when a patient first has hypertension or their blood pressure is slowly increasing. Now let's get into diuretics. Diuretic medications primarily work in the kidneys to increase the excretion of water and electrolytes from the body. There are different types of diuretics, each targeting specific parts of the kidneys' filtration and reabsorption processes. Loop diuretics, these act on the ascending loop of Henle in the kidneys, inhibiting the reabsorption of sodium and chloride, which leads to increased urine production and fluid loss. Thiazide diuretics work in the distal convoluted tubules, reducing the reabsorption of sodium, chloride, and water, which results in the diuresis and decreased blood pressure. Potassium-sparing diuretics act in the collecting ducts and decrease the excretion of potassium while promoting the excretion of sodium and water. Carbonic anhydrase inhibitors affect the proximal convoluted tubules, reducing bicarbonate reabsorption and subsequently sodium reabsorption, leading to diuresis. Lastly, osmotic diuretics are filtered by the glomerulus but are not reabsorbed. They increase osmolarity in the renal tubules, preventing water and reabsorption and causing diuresis. Each type of diuretic has a unique mechanism and application. They are often prescribed to manage conditions such as hypertension, edema, and congestive heart failure. It's important to note that the use of diuretics should be monitored by a healthcare professional, as they can affect electrolyte balance and kidney functions. So we'll be going over each medication and how they work, the medications in their class, and the different characteristics you need to know for the NAPLEX exam for each medication. Thiazide diuretics exert their influence at the proximal distal convoluted tubule. So here are the list of thiazide diuretics. You can see here hydrochlorothiazide, microzide, and so forth. I would recommend knowing the brand and generic medication name and the MOA and where it works. And it's important to know that thiazide diuretics cannot be used in patients with creatine clearance less than 30. The only thiazide diuretic that can be used, which is considered a thiazide-like diuretic, not a pure thiazide diuretic, is metolazine, Zeroxyl, which is given daily. And this could be given to patients with creatine clearance less than 30. So this is the only thiazide diuretic that can be given to a patient with a creatine clearance less than 30. And loop diuretics is recommended for patients who have creatine clearance less than 30. But it is important to know that metolazone is the exception to that rule. Now let's move into thiazide diuretics, cautions, and side effects. And I would recommend knowing these for the NAPLEX exam. There are quite a bit of them, but they are important since thiazides play a big role in hypertension management. So these include sexual dysfunction, sulfa allergies, diabetes, dyslipidemia, gout/kidney stones, renal failure. It is important to note that thiazide diuretics cannot be given to patients with creatine clearances less than 30, except one medication, which is a thiazide-like diuretic. So which medication is that? Correct. Zeroxyl. So it's important to note that and to know that for the exam. Next, it could cause hyponatremia. As for electrolytes, it does deplete all electrolytes except calcium. And it does increase glucose, uric acid, and calcium. So I like to think of it as guac. So thiazide diuretics increase guac, which stands for glucose, uric acid, and calcium. Next up, let's get into thiazide drug interactions. So thiazides could interact with several medications because it does deplete several electrolytes. But here are the notable ones for your NAPLEX exam. A good mnemonic to memorize them is DALE, which stands for digoxin, allopurinol, and lithium. And it's important to know, obviously later on we'll get more into it, but digoxin toxicities could be due to a decrease in potassium and magnesium, while lithium toxicities could be due to a decrease in sodium. Next, hold on to your hats because we're about to ride the loop diuretics roller coaster. These diuretics are like the rock stars of fluid management, setting up camp in the thick ascending limb of the loop of Henle. First up, we've got the Rebel ethacrynic acid, which has no sulfa in it, which is the only loop diuretic with no sulfa. Next, we have furosemide, Lasix. Next, furosemide, Dimetics. And lastly, but not least, bumetanide, Bumix, which has a maximum dose of 10 milligrams per day. So loop diuretics are very important because they can be given to patients with creatine clearances less than 30, as you can see here, which you can't give with thiazide. So that's why it's important. If a patient has a creatine clearance less than 30 and we need a diuretic, loop diuretics are perfect. And they can be used, their indications are edema, hypertension, and hypercalcemia. Now, for the most part, loop diuretics are very similar to thiazide diuretics, which include their sulfa allergy, sexual dysfunction, all of those side effects. But the differences are that it decreases all electrolytes and it increases glucose, uric acid, and lipids instead of increasing calcium. The main differences between them in terms of their side effects profile is loop diuretics is ototoxic and it is kidney okay, meaning you could give it to patients with creatine clearance less than 30. So a good way to remember this is if you see loop diuretics, you could use the two O's in loop as a reminder as ototoxic and okay to give in patients with creatine clearance less than 30. Last but not least, we have case-sparing diuretics, which work in the distal convoluted tubule and the collecting ducts. And these diuretics are not to be used alone. The main ones being aldosterone antagonists, which is spironolactone, aldactone, and eplerenone inspira. And it is important to know that spironolactone, a side effect to this medication is gynecomastia. So on the NAPLEX, they could give you a patient scenario where a patient comes into the pharmacy saying they started a new medication and they noticed that, the male started to grow, man boobs. And in this scenario, they could ask you which medication could have been a cause of this. And it would be up to you where you would have to know that that is a side effect of spironolactone. So the main side effects of these diuretics include hyperkalemia, which makes sense, hence the name case-sparing diuretics, hyponatremia, rash, and headache. Moving on to beta blockers. Now, this class of medication is very important. You'll see them throughout the NAPLEX and throughout several other disease states. So here are a couple of them. I would recommend knowing their brand and generic name and a couple of their characteristics noted on the slide. Here are the rest of the beta blockers, and I just wanted to note out for the NAPLEX exam, a high-yield question is usually about carvedilol, Coreg, where they could ask you whether it's taken with food or not, and usually the starting dose for CHF and hypertension. Usually the question will look something like, the pharmacist wants to start carvedilol for a patient with CHF. What is the starting dose for this patient? And they could give you the CHF dosage, the hypertension dosage, which will be 3.125 BID and 6.25 milligrams BID, and a couple other dosages, and it will be up to you to know the starting dose for each disease state. So beta blockers could be further categorized into B1 selective, which stands for beta blockers that are more selective towards your heart. And a good mnemonic to know for these are amoeba. So I would memorize these for the NAPLEX exam. And a good way to remember the differences between each beta blocker and its where it works is B1 works on your heart, and you can think of it as the one indicating that you only have one heart, while the B2 selectively works on your lungs, and you have two lungs. So D2 could be a reminder of the beta blocker working on your lungs. Another category to divide beta blockers into is the beta blockers that are available in IV formulation, and the mnemonic for these is me. Next, we have a group of beta blockers that have intrinsic sympathomimetic activity, ISA activity, which don't increase resting heart rate, and you can memorize these as ACE, PIN, PEN. So we'll be seeing beta blockers throughout this course, so it's important to know beta blockers indication, and a good mnemonic for this is PASS, which is post-myocardia infarction, which is a heart attack, angina, AFib rate control, and for CHF, systolic heart failure. Beta blocker side effects could be memorized through the mnemonic of blocker, get it, beta blocker. The B standing for bradycardia / bronchospasms. L for lipid increase and libido decrease. O for orthostatic hypotension. C for conduction abnormalities. And the K, we know constriction starts with a C, but just go with it. So K standing for the constriction of peripheral vasculature. E standing for exhaustion / emotional depression. And lastly, R standing for reduced recognition of hypoglycemia, and it could also cause hypoglycemia. Moving on to the next category of medications, which are calcium channel blockers, and these are divided up into two categories, which are non-DHP calcium channel blockers and DHP calcium channel blockers. Starting off with non-DHP calcium channel blockers, these are negative ionotropic and negative chronotropic medications, so they are to be used with caution in patients with CHF, heart blocks, and hepatic dysfunction. You don't want to give these medications with lovastatin, simvastatin, or erectile dysfunction medications. You don't want to give these medications to patients with bradycardia or who have heart rate exacerbations. And this class of drugs include diltiazem and verapamil. And I would recommend knowing the brand and generic name for both of these. The other type of calcium channel blockers are DHP calcium channel blockers. And as you can see here, here's a list of them. I would recommend knowing the brand and generic name and the different characteristics for each medication. And it is important to note that DHP calcium channel blockers is the drug of choice for Raynaud's disease. Here are the side effects for calcium channel blockers. Moving on to ACE inhibitors. So I would know these medication, their brand and generic names. And it's important to know that they all have the ending in pril. So that is an easy indicator to know that it is an ACE inhibitor. Unfortunately, on the NAPLEX exam, they could give you the brand name, which you would have to know that you would have to know the brand and generic name to know that it is an ACE inhibitor. A few important characteristics to point out for ACE inhibitors are IV ACE inhibitors. The only ACE inhibitor that comes in IV formulation is enalapril, which is enalaprilate. Next, oral solution, same. Enalapril comes in an oral solution and IV solution in IV formulation. Next, you have capsule ACE inhibitors. The only ACE that comes in capsules is ramipril. The shortest acting ACE inhibitor is captopril, which is given 3 times a day on an empty stomach. And the ACE inhibitor that is safer in renal impairment is lisinopril. ACE inhibitors are recommended in these disease states, so it's important to know when to recommend as a pharmacist an ACE inhibitor and the different characteristics for each one. So obviously later on in later lectures, we'll go more in depth for each disease state and how ACE inhibitors play a role in each of them. Next, let's get into ACE inhibitors, side effects, and contraindications. So ACE inhibitors do increase potassium, K, so it could lead to hyperkalemia, which could also lead to hyponatremia, low sodium, since they're opposite of each other. It could lead to serum creatinine increase due to its kidney effects. So you don't want to give it to patients who have a creatine clearance less than 30. You want to avoid ACE inhibitors in pregnant patients. You want to avoid salt substitutes. And you want to be cautioned of angioedema due to bradykinin. And angioedema is a medical emergency. Therefore, if a patient experiences angioedema, you want to go straight to the ER. A good mnemonic to know for ACE inhibitors interactions is CAL, which stand for case-bearing diuretics, ARBs, allopurinol, and lithium. Next, moving on to ARBs, which are very similar to ACE inhibitors, except they displace angiotensin II on the AT1 receptor. And their side profiles are very similar, except that ARBs do not increase bradykinin as much, so therefore there isn't much of a cough. So if a patient does complain of coughing while being on an ACE, you could consider switching to an ARB. Here are a list of the brand and generic names for ARBs. I would be familiar with these for the exam. A good trick for telmisartan, I like to remember it as tell me what my card is. And you could, remember that as telmisartan. The brand name of it is Mecardis. So it could work, it could not, up to you. Entirely anything that works for you. Any way to remember these, whatever trick, mnemonics, whatever way that works, go through with it and make sure you have these down for the exam. Next, we have Tecturna, brand name Aliskiren, which is a direct renin inhibitor. Moving on, we have alpha-1 adrenergic blockers. And here's a list. I would know brand and generic of each of them and which disease state they treat. And you can see here, prazosin is used for hypertension only. So it's important to know that prazosin is the only alpha-1 blocker used for only hypertension. Next, we have doxazosin, tirazosin, doxazosin ER, tamsulosin, and so forth. So I would know the different characteristics for each. A good mnemonic to memorize the side effects of alpha-1 blockers is FO, which stand for floppy iris syndrome, orthostatic hypotension, and ejaculation retrograde. And you don't want to give these if the patient has a creatine clearance less than 30 or has any cardiac issues. Next, we have alpha-2 agonists. These decrease norepinephrine, which decrease the sympathetic system, which ultimately decreases blood pressure. So for these medications, I like to remember them as alpha-2 being agonists and alpha-1 being antagonists. So that's a good way to memorize these MOAs, as in the NAPLEX exam, they'll give you an alpha-1 blocker or an alpha-2 agonist, and they'll ask you what is the MOA of it, in hopes of getting them confused between alpha-1 and alpha-2 agonists and antagonists. So just remember alpha-1 for these medications, alpha-1 antagonist, alpha-2 agonists. They're kind of opposites of each other.
Side effects for alpha-2 agonists include dry mouth, sedation, constipation, orthostatus, and rebound hypertension.
And last but not least, our last class of antihypertensive medications are vasodilators, and these work by increasing cGMP. And in this class, we have hydralazine and minoxidil. And a class side effect for these two are reflex tachycardia and hypotension. So it's important to note these two. So now that we have gone over all of the medications for managing hypertension, let's get into a couple combo drugs. I would know these, memorize these. They could be given throughout your NAPLEX. They could be given in your law exam, whether the MPJE or the CPJE. So I would just memorize these throughout. First category of combo drugs are CCBs and ACE inhibitors. These include Lotril, Tarca, and Prestella. Next, we have combo drugs that are calcium channel blockers and ARBs. These include Exforge, Twinsta, and Azor. And you could see here under those three, we have a 3-drug combo, which is Tribenzor, which is crazy because this could, ultimately help the patient's pill burden. So it's important to know these, these questions are asked in terms of the patient is on amlodipine and olmesartan. Which other medication can the pharmacist recommend to lessen their pill burden? So then the answer would be Azor. So the questions on the NAPLEX will be formulated like that. And here we have other combo drugs I would recommend knowing for the exam as well. And that concludes our masterclass on hypertension. I hope this video helped. Thank you for watching. Please like and subscribe for more, and we'll see you in the next masterclass.